At the workshop coming up, we have some very exciting things to cover. We're going to look at 7 different things that you'll get to do. There may be some more that we add in for future workshops.
And we decided to record this as a video so you can review at your leisure, but please be ready during the workshop so that you have something to follow along.
So taking a look first, these are the 7 main skills. We'll just give some brief comments about each of these. And we'll start with gonioscopy as one of those skills that we all need to continue practicing. It still is on boards also.
And there's 2 different kind of gonioscopy lenses. I tend to prefer the 4 mirror one without a flange. You can get it into the eye easier. It's you can tilt it, you have more manipulation, you have a better view of the angle, but the most commonly used in boards, as far as I know, is the one with the flange, which stays in the eye more easily, and there's only one correct position because you can't tilt and move around as easily.
Looking at the next skill, punctal occlusion. Now there's different videos that we've done for all the different types of punctal plugs. One of those that you'll be using is going to be one that you actually load yourselves. And this is going to be with this black injector here. There's a very fine tip on the tip of it. And as we can see here, this silicone plug is going to actually be loaded by you. It comes out of a small baggie that we'll show you here.
And the little baggie is both your enemy and your friend. It does keep the plug in place, but sometimes because of static, this is very difficult to get off. So as you use, you can try to do it in the bag. I've now sometimes taken them out because they will stick also to your finger because of static, and then it behind the slit lamp. Once it's out, please take an alcohol wipe and kind of squeeze it around just so that you disinfect one more time before inserting it into the patient.
A question I get a lot is, how do I know if the plug went in? And I want to have you pay particular attention right here where that plug is going in. You're going to actually see the eyelid margin just indent slightly. And that means it's not in yet. At a moment, there, it snaps into place and that plug is now in. You can push the button to release it or start pulling it out as well.
And yeah, if you pull up, you'll just notice that the eyelid will come up because the lower part, that little kind of arrow, is now inside the punctum, and so has some retraction. So pulling up just make sure that the top is outside the punctum. So please don't insert the punctum the plug into the punctum all the way. So I always want that lid, this one, to be on top, not underneath the punctum.
That's a good point, and I just want to go back to the beginning of this video one more time right here. There's the indentation, and there it snaps into place. That's how you know, okay, the plug is where it should be, but I agree, do not continue pushing deeper past that point.
And you'll be able to feel it, the patient can feel it too. Now getting it out, same idea, you try and grab it at the neck, pulling it out. Do not try and grab it at the lid because that can tear. And then as soon as you grab it by the neck, pull as hard as you can. You'll be able to just lift it up and take it out.
One more view of what that looks like with forceps, grabbing right at the neck of that punctal plug. Avoid the flimsy part at the top and grab right at the neck of it, and that should come out very swiftly in most cases.
And again, both in and out, the patient will notice you kind of able to feel a little bit of a little give, I guess, a little pop. And patient will sometimes say, it's like, oh, I felt that pop in. Now, as an alternative, besides the plugs, say patient feels irritation, but didn't have too much tearing, or they just don't like the idea and you've already tried a collagen plug, which only lasts 7 to 10 days. You can do Lacrifill, which lasts 3 to 6 months. The more you can get in, the better. The deeper that cannula is, the better. This is just a brief overview. I think it's better done in person than in a video.
And what we'll do at the workshop is if you can do something like dilation and irrigation, Lacrifill should be no problem at all. So now just for a quick little demo of what that looks like preparing the syringe and the cannula.
And syringe, the more volume you have, the better. This is a 5cc syringe. That just allows you to put more, just by hydrostatic forces, more pressure in. And so this cannula is in your kit. It has a thinner tip and then this little bulge. That little belly, if you will, you're supposed to put it in until the punctum meets that belly because that provides a thin entry point and then it seals around this and then you can push. I like to do everything outside the punctum and outside the slit lamp, obviously. Punctum is an obvious statement. And the filling it up, you heard there's a little bit of a pop, but if you leave this on, you can now just fill in the eye wash. And even though there's might be a little bit running out, there won't be a lot. If this was open, obviously it would run out a lot. You can see a little drip. And then turning it around, hopefully not pointing it at anyone, but you'll get a little bit of a thing, and now you're ready to go. And again, everything for me is done outside a slit lamp. It's just having the patient lean back because then they also can pull back.
So then getting back into what this actually looks like, If we take a look, in some occasions, that cannula that was used does not get into the puncta. The puncta is too small. We can see here an attempt at getting in, it's not going in. Now, one way to get around that is actually dilating the puncta. You all have your punctal dilators, very, very fine-tipped tools. And in this first video, we can see an attempt at doing that. Now, I think this might not be quite aggressive enough to truly dilate a puncta. You may need a little more tension on the eyelid to really get that probing deeper.
So again, I like to do this outside. Sometimes loops are helpful, getting it in first. And then as you go more towards the nose, you flatten out your dilator, and then you can really bore and pull a lot. And that dilation can sometimes help patients who have intermittent tearing because of a small punctum. They can get some relief for that for a day or two, and then at least helps you diagnose that's where the problem is. So I also start with the smallest. If it's really tiny, slit lamp is helpful. Otherwise, you can't get it in. And once you've dilated a little bit, then you use the larger one, and having an assistant ready to just hand you the syringe as soon as you're out is helpful, because the punctum will shrink down again after you stop dilating.
It's tempting to also look for a smaller cannula, may be necessary in some cases, but you're not going to get as much volume into the cannulicular system. So that I don't think is our first choice option, but in some cases may be necessary.
Correct. So if you think of this again, like this small syringe, like I can push down 1 cc very easily, but this is because there's a large bore up here. So you can also sometimes build enough pressure to flush out any small resistance, or maybe a small mucus plug that might be leading to some extra tearing, and that can be helpful in relieving patient symptoms.
And if you can do that skill that we just saw right there, you can also do Lacrifill, that other version of a plug. Now, sutures. We're going to encounter a lot of sutures in clinic. Sometimes they're already loose, like we can see right here. That's already a loose suture that could be grasped with forceps and pulled out. Sometimes these sutures are actually broken and embedded complete in the cornea. Those may not be necessary to go after at all.
And then the reason to get them out is this, as you can tell, can lead to a small entry point and kind of some inflammation and some infection down the line. So you want to get these out. If they're not broken, then I break them with a needle going underneath with the bevel up. So here you kind of see it sideways, then standing it up this way. And then that allows me to lift it above the epithelium, and then allows me to retrieve that. So again, breaking the needle first, cutting it, and then maybe going sideways a little bit. You always want to pull the knot, this little thing, the least distance, the shortest distance. So if you have a knot that's here, you want to cut it on this side. If the knot would be closer to here, you're going to cut it on the right. And in this one, you see kind of more that removal and that short little tug, almost like taking out a lash.
That's very quick, that little tug and pull. And I want to reinforce that kind of two-step thing with the needle. It's not just breaking the suture, but it's also lifting it out of the epithelium as well. We use fake eyes in our clinic for the practice for you, and what that looks like is going to be very similar, though you're not going to get the depth of the cornea. It's going to look very dry relative to what the cornea looks like, but similar process.
And then there's way more tension, and since there's no epithelium, it's way easier to cut. You don't have to get underneath. But again, the idea and the motion is very similar.
Another skill that we're going to cover is bandage contact lens insertion and removal. This video should walk us through that technique. You're all probably very familiar with doing bandage contact lenses, but this is going to walk us through holding the upper lids and lashes to keep those out of the way, inserting the bandage contact lens on the superior part of the sclera. Patient blinks and that recenters. This is showing sodium fluorescein, but also in our workshop, fluoresce is a very common thing to use as well.
Just to remove, always going with forceps. Temporally, you have more space. Grab one edge, break the seal, and slowly pull it off. This is not a little tug, this is more slowly removing it, not a fast.
You can see both in the slit lamp and out of the slit lamp view now as well. I like to stabilize my hand on something, usually the patient's face or the slit lamp, so that your hand holding the forceps is very steady. Sometimes the first attempt doesn't get the bandage contact lens out, so just pull right on the edge and pull it out.
And again, it's like, yes, the more sliding it off rather than pulling. And then now I think a lot of you have done this already. If not, we'll get to this, but mammary gland expression. This is a skill that is done in combination with IPL or one touch. Oftentimes the debridement itself can be helpful too. So you just gently slide along that lid margin from one side to the other. And ideally, if it was tilted a little bit more, you have the edge, but you don't need to scrape. Now, I have a strong preference for these expressors. You can see this is not too comfortable, but definitely more comfortable than the Mistrata paddles. You have more control. You have two smooth surfaces the Mostrada paddle and the Q-tip is way too much pressure. I've had several patients refuse the Mostrada paddle expression and say, nobody touches my eye with that ever again, because they felt worse afterwards than doing it this way. And those same patients I expressed with these expressors, and they were very happy to come back and let me do that again. You put enough pressure in so that you see something come out, and then hold that pressure. Do not increase the pressure.
Upper lids tend to be a little bit more challenging. This is probably as good as you can get for the placement. I might try to get a little bit closer to where the oil is going to come out, but you run the risk of getting too close to that edge, then you're going to snap your expressors off the lid, which makes a loud noise, and it's uncomfortable for the patient also.
And always two hands, so the one hand stabilizes the lid, the other one helps with the expressor. And the upper lid, you turn the tarsus by pushing underneath the lid to kind of elevate it, and similar process actually here with the speculum insertion. Getting it out, maybe also remember that this way is holding it open, but if you were just to rotate it, it doesn't hold anything, right? That's one of the last ditch efforts. Like, I can't get it in, I was like, just rotate it. And this hand, ball of your thumb, ideally put that on your forehead, look down, and then this goes right above the lashes, so you can move the lid out of the way, and then this goes not like that, underneath the upper lid, and then you push up. See, I kind of let go of this one. Look up. I'm exaggerating right now. And then just the lower lid, and go slow, please. And look straight ahead. How are you doing? Good. No, not great, I know. No. And then getting it out is the opposite. So you first remove the lower lid, and one more thing. Look down. You see how there's no space right now here? Look up, and now you have space. So look up. That's how you get underneath. Get this one out first, and see how I'm rotating it a little bit too? Yep. Look down, and then you either control the upper lid or just get it out, meaning go down, but never go this way.
So a good example of how to do those 7 different skills at the workshop that we're going to be doing. Looking forward to this workshop very much. If there's any questions, let us know, but that'll be a lot of fun when we come do this together.